I'd like to welcome you all to the last session today, and we have our speaker, our keynote, Dr. Veenu Gupta, with us today. Veenu is an assistant professor in lived experience research at Durham University. She has lived experience with psychosis herself and worked as a service user advisor to the National Clinical Audit of Psychosis from 2018 to 2024. Across her many roles, Veenu seeks to integrate both personal and professional elements of her expertise to inform and shape research that better meets the needs of patients. She was part of the Durham team that was successfully awarded a commission by the Wellcome Trust to explore how subjective experiences can be better integrated into mental health research. That's called the Sunrise study. Veenu will be contributing to the Safe Paths study exploring how South Asians and their families' experiences of psychosis can lead to better pathways into services. I've had the privilege of working with Veenu, and she is an incredibly impressive and inspiring researcher who is an important voice in lived experience research. As such, it's my absolute honour and genuine pleasure to introduce Veenu to all of you today. Thank you very much.
Thanks, Susie. I think she's done a better job of that introduction than I'm going to do right now. So anyway, hello everyone. I'm Dr. Veenu Gupta, assistant professor in lived experience research. I'm going to be talking to you today about how to support and empower the lived experience workforce. I'm going to reflect a little bit about the evolution of services involvement, drawing on some of my own past experiences of lived experience, and also thinking about currently what the lived experience workforce field looks like and opportunities for the future. So I wanted to say lots of thank yous because actually I wouldn't be here today with a lot of these individuals supporting me. So thank you to my immediate family, my mum, dad and sister, for weathering the storms that I've faced. I couldn't do this without you. And thank you to all the experts by experience, trainee psychologists, experts by qualification, carers, lived experience researchers that had contributed to my research. And again, thank you to all the research colleagues for all of the opportunities that have been afforded to me, but also for the opportunities to check in when I've needed it. It's facilitated my own recovery and ability to work in this role. And a massive thank you to Professor Andrew Gumley for inviting me to talk, and also to Edinburgh. So the theme of this presentation is around time, and actually I've grown so much over time and developed a lot in terms of who I am and what I contribute now to research. And actually, when I was floridly psychotic, I did sort of try to time travel. So, you know, it has a little bit of significance and permanence there. So this poem is something I wrote in 2017 when I started my The Teal Tiger blog. So where I have been, where I am now, where I'm going next. My mind is a time traveller, memories hold on to the past, my conscious mind makes sense of the present, and I dream of an unknown future. So I wanted to tell you a little bit more about who I am and where I've been and where I'm going. So I started off as a patient of early intervention in psychosis services. I was diagnosed with paranoid schizophrenia, and I actually experienced the gold standard care that set me on my road to recovery. So I had both social, psychiatric and psychological support. And that was really the roots into kind of me wanting to contribute to research and clinical practice to kind of inform research and services to better meet the needs of patients. So because I had a positive experience, I wanted to use that as an expert by experience and contribute to clinical psychology training, but also I've worked as a service user advisor to the National Clinical Audit of Psychosis as well. In terms of that, I've also had some clinical experience working as a support worker and also a mental health nurse, but I realised actually that the expert by experience role, where I was able to draw on both my personal and professional expertise, is something that I found personally meaningful. And so I was able to do a PhD to explore how those in lived experience roles are impacted by those roles and how they influence their own recovery and identity. And so I've also had an opportunity to do a postdoctoral research position on the Extend Early Intervention in Psychosis study. So that actually has drawn on big data. So I have an understanding of both subjective experiences, but also kind of quantitative research and also big data. And also in terms of my current role, I am an assistant professor in lived experience research. So we were just sort of reflecting on roles and titles and how they ascribe expertise. And actually this particular title, I have a privilege to kind of adopt that title, and actually it legitimizes my own lived experience in spaces where there often are very different power dynamics in the room. So yeah, so it's the end of the day, but I'm going to give you a bit of a history lesson. So reflecting on the past and thinking about service user involvement and where it's come from. So if you think about people's experiences, unusual experiences, experiences of psychosis, depression, you know, these individuals were kind of almost viewed in freak shows in the past and segregated from the community and locked and viewed up in as freaks, you know, in freak shows, and segregated from society and locked into asylums and mental health institutions. And so as psychiatry grew out of the medical field, you know, there were clear role constructs being developed where patients were being done to and coerced, and actually psychiatrists or psychologists were the ones with the power in the room to impact these service users. And so you can see that there are clear role identities being constructed. And actually in opposition to psychiatry, there was this emergence of the recovery movement and the survivor movement, but also in parallel to that, the consumer movement, where essentially patients could be viewed as experts and people to learn from, and the understanding that people could get better and recover from their experiences. So within kind of the consumer movement and experts being seen as people to learn, or service users being seen as people to learn from, you know, those role identities are being blurred, and actually, you know, you've got these identities which span both service user and professional. So just thinking about the current history or where we're at right now in terms of the lived experience field. So in research settings, you've got experts by experience or patient and public involvement members who contribute to research to kind of make sure that the research is meeting the population's needs and that we're identifying questions relevant to service users. And actually, so there are different types of lived experience work. So you might have lived experience researchers who are kind of actively integrating and informing the research based on their own lived experiences and researching things relevant to them. So you've also got peer workers in clinical settings who kind of support conversations or assessments with patients in those settings. And actually it's about opening up those conversations and addressing kind of the power imbalance in the room and supporting shared decision making. You know, these lived experience roles are bringing our personal experiences to the table, this emotional dimension to this work, and actually it can leave us vulnerable, and there are many different challenges that we might experience in this workforce. So one of the kind of issues that was touched upon earlier is that actually lived experience work is now being mandated. So there is a requirement to have lived experience work in research and clinical practice as set out by NIHR and also HCPC in the UK. But as a risk of that, there's a risk of tokenism in that people might just be engaging in this work because they have to. And so how do we make that actually a meaningful process? And I'm hoping to kind of discuss a little bit about that today and how we might support the lived experience workforce. I think there's also this idea of epistemic injustice, which is about how individuals from stigmatized patient identities might be viewed through that lens, and actually the knowledge that they produce might be doubted as a result of that. But if you flip that on their head, you know, people in lived experience roles actually value more authentic experiences and the knowledge that comes from service users. So I was really interested and moved by Graham's experiences that he talked about earlier. And then in terms of the them and us divisions, there are also them and us divisions, not just between clinicians and service users, but also within the lived experience workforce. So you've almost got an invisible hierarchy where, you know, mental health professionals with lived experience might be perceived as more knowledgeable and more higher up than the expert by experience with no kind of formal qualifications. And actually that knowledge is almost, that isn't a useful way to think about lived experience. And also there are many different benefits to people in these roles. So these roles actually fuel our own recovery. They also impact our own identity and are empowering and give us many ways to grow and transform. So I wanted to talk a little bit about my PhD research, which was hoping to understand the identity of those in lived experience roles. So we came up with a conceptual framework from which to describe this. So this included experts by experience, peer workers, mental health professionals with lived experience, and lived experience researchers. And essentially, we found that those in these roles had to navigate both personal and professional areas of their expertise. And actually, it wasn't always easy to integrate those experiences. And sometimes actually there was a conflict there, and actually it was hard to draw on, but simultaneously draw on both areas of expertise. And that might have been due to issues around stigma and discrimination, for example, or the professionalization of the role or expectations to be in recovery. And sometimes people occupy the space in between, so a liminal space, either between service user or professional, where essentially people didn't really know who they were talking to when they were encountering an expert by experience or what they could bring to the room, even though that individual had a good understanding of who they are and what they could bring. And so we also identified the emergence framework in my PhD research, which were themes that influence the positions of identity. So I'm going to start from the bottom and work my way up. So essentially, people were in survivor routes. So these were the routes and drivers for them to perform their roles, even if the roles were emotionally burdensome or laborsome, because they had those either positive or negative experiences or survivor use. This fueled them to kind of contribute to this work. There's also these ideas around exclusion, stigma, and discrimination. So often people in these roles, it was a very white population, it wasn't very representative, it wasn't inclusive. So actually what we need to do is move towards more inclusive representation within this workforce. Again, in terms of feminist positions, we've spoken about that invisible hierarchy that is not just between the service user and the professional, but it's also within them. So yeah, we need to find ways to challenge that. Again, there was also this idea of growth and transformation in that people could become a lot more who they were, and they had moved beyond their service user histories. And actually, not only that, they don't just grow and transform internally. What they're also doing is growing and transforming the service and the research that they're contributing to. This research is all based around or contextualized or situated in the recovery model and the medical model. So this theme kind of speaks to the ideas around the power dynamics that people navigate in these roles, and almost how there's an expectation to be in recovery and further removed from their diagnoses or their service user histories. Often in these roles, there's a social domain in which people are sharing their experiences, talking about those experiences, listening and learning from others. And what people do is construct narratives from which to describe their own experiences. And actually, through hearing other people's experiences, through sharing their own experiences, they come to understand what their own personal experiences basically. So that theme is the empathy of the self and the others. And again, out of all of this, there's a motivation to integrate. So even if the work is difficult, even if the work is kind of stigmatizing, people want to actively integrate their lived experience into their work. And again, by drawing on personal and professional expertise and having the training from which to do their roles, this is enabling and empowering. So I wanted to delve further into some of this understanding around the positions of identity. And what we did was, based on the supervisory expertise in my team, so me being an expert by experience, and my supervisors being experts by qualification in the context of clinical psychology training, we decided to conduct focus group research to understand the social constructions of identity in clinical psychology. So essentially, we found very similar results, but with a bit more nuance and a bit more subjectivity. So people actually were navigating both personal and professional identities, but actually sometimes there were competing narratives in terms of whether they wanted to separate those two. And sometimes the decision to separate them was based on separating from the emotional burden of that role, or for trainees not to become a therapist for their own family members. And so there was this idea to distinguish from their personal lives and from their professional role. There was also these motivations to integrate. So actually experts by experience wanted to channel their own experiences into the work that they were doing, which fits nicely with the systematic narrative review. But actually trainees also wanted to know how to do that, but actually didn't feel expert or know how to do that confidently. One of the big themes was around visible and invisible identities, but there were clear role constructions occurring here in that experts by experience felt that their whole purpose was to be visible in the room and to talk about their experiences. So this individual says, sometimes our voices are just not heard, and sometimes we're going to be stepping on people's toes because we need to be heard, that those doctors can't admit to being a service user. So it's almost saying that the expert by qualification doesn't have that role in terms of talking about that lived experience. And actually it's the expert by experience who needs to take on that role, basically. So we talked earlier about labels and how they can ascribe power. So, you know, language and labels were really useful in terms of rebalancing power or giving people more power. So as a result of this study, we identified that, you know, ascribing expert status to kind of experts by experience or expert carers was something that kind of flattened the hierarchy or actually redistributed that power. There were also them and us divisions between groups, and actually how there was a motivation to negotiate those them and us divisions and work effectively with those with lived experience in the room. So it's very difficult getting in that them and us space, but we've got a good care coordinator of service user experience who pours oil on troubled water and keeps us all in line, steering that difficult path between how we get things changed and not alienate everyone in the process. So this almost speaks to the idea of negotiation around service user involvement, and actually it's a co-produced kind of thing, and actually it's not easy. It's something that requires work, time, resources, but also a navigation. And actually most people, all of the stakeholders spoke to the idea that they could all be learners or experts in their roles. So these learner and experts were constructed in opposition to one another. And so it wasn't always the expert by experience who was the learner in the role, but it was also the expert by qualification who was learning how to do this lived experience work effectively. So looking to the future, you know, there's ways that the lived experience workforce can be developed, can be enhanced. It's really important to work towards user-led initiatives, to think about democratic approaches, thinking about rebalancing that power and flattening that hierarchy. It's also really important to provide guidelines and infrastructure and resources for people to do this work effectively. And then there are a whole host of other ideas that, you know, the lived experience workforce can be supported through, but I'm going to do a deep dive into some of my PhD research, which is on supervision specifically. So essentially, we distilled all of the different ideas from across my PhD, so 54 item statements, and we presented them to 18 lived experience researchers to organise on a force distribution grid to understand how they prioritise or organise these statements based on priority on supervisory topics important to them. And then we subjected that to an inverted factor analysis. So we were talking earlier about subjectivity and objectivity, and actually this is a Q methodology which almost legitimizes subjective methods with a quantitative approach. So based on that inverted factor analysis, where participants are the ones that load on to factors, we found that there were 3 different unique types of lived experience researcher. So the first factor was an individual who was focused on strengthening their identity, skills, growth, and empowerment. The second was focused on emotional relational link to the research. And the third was focused on navigating their lived and professional experiences practically and emotionally. So I'm going to tell you a little bit more about those different researchers. So factor 1, strengthening identity, skills, growth, and empowerment. This type of individual was focused on a strengths-based approach to supervision that was empowering, that was affirmative, that helped them grow and help build their confidence. So this type of individual actually wanted to move further away from their service user histories, and they didn't want to feel like they weren't effective or had skill or didn't have skills to do their work. They wanted to feel like they were skilled enough to do their roles. So essentially, this individual says, I think empowerment and recovery of growth are more of a priority. And so some of the item statements that loaded onto this were things like discussing the skills and abilities I have in my role, strengthening the identity and lived experience of me as a lived experience researcher. So yeah. So factor 2 was focused on exploring the emotional and relational link with the research. So this is essentially speaking to the interaction between people bringing their own lived experiences to the work that they're doing and the impact that they have on research, but also vice versa, the interaction of the research back on them as those with lived experience. So this type of individual can be supported through things like reasonable adjustments, through discussing their well-being needs, through discussing or having spaces to be reflexive and reflective. And this type of individual was actually more introspective in nature and was conducting research more closely tied to their own lived experiences. So this individual says, knowing that you can relate to the research topic and the participants, because you know you have shared similar experiences is one thing, but knowing how to use this relatability during your work, I find is a skill I don't know how to use naturally. So this individual, almost the items that loaded onto this factor were things like exploring how I relate to the participants in the research, exploring how I relate to the research topic. So factor 3 was a holistic type of support, which was navigating lived and professional experiences practically and emotionally. So these individuals wanted to support to overcome the barriers that they experience and also to navigate the many different identities that they have. And actually, they wanted a personalized level of support spanning practical, emotional, and administrative support, including financial support and payment for their work. So this individual says, I have a personal life but still need support to actually do the role in practical terms, yet with my supervisor providing emotional support when needed. So this speaks to the idea of personalizing support. So if we go back to the emergence framework and think about how these different factors can map on to these different areas, so you can see that factor 1 is localized around the top end of the emergence framework, which is obvious because it's around empowerment, motivation, and growth and transformation. So you can see how those themes fit nicely with that. And then factor 2 is emotional and relational links. So thinking about motivations to integrate, thinking about social domain and empathy, thinking about exclusion and survivor routes. And then factor 3 spans the entirety of the emergence framework, thinking about drawing on each of the different domains in that framework. So we did actually publish this research, and we published it in research involvement and engagement, which is relevant to the population that it is about. So, and we've managed to disseminate it with not-for-profit organisations such as McPin Foundation as well. So just sort of synthesizing all of that work back into the emergence framework, I think in order to empower and enable people, it's important to provide them with the relevant skills and training that they need, as well as thinking about how they can draw on both their personal and professional experiences. And again, providing reasonable adjustments for them to do their roles effectively. Again, thinking about labels used to describe them. So do we want to give them a director level role? Do we want to give them an expert label in their title, for example? Motivation is really important to find ways to integrate these experiences into the work that we're doing. Again, it's important to provide a social domain for people to talk about their experiences and to discuss them and have a space for them to learn from others' experiences. Again, we also need to reflect on the power in the room. If you're the one that thinks if you don't see the power in the room, it's probably because you're the one that has it. So it's really important to reflect on that. And again, it's important to think about how people conceptualize their own experiences, because actually they might very well differ even within those in lived experience roles. So growth and transformation, again, like I said, it's not only about the growth of the lived experience member, it's also about the growth of the team and the research. Exclusion and stigma and discrimination, we need to really actively challenge exclusion and find ways to be more inclusive. Thinking about EDI approaches, intersectional approaches, and anti-racist approaches. And again, survivor routes, we need to really understand the history of these individuals that are working in these roles and ensuring that we're providing them with the relevant support that they need. So I am going to wrap up very soon. So I just wanted to talk about the many different opportunities that I've had as a result of my lived experience roles. So I've had the opportunity to inform national audits. I've had the opportunity to inform national research, national policy, as well as work with not-for-profit organisations in the field of lived experience, as well as work at Durham University. So just very quickly circling back, very recently I became a patient again, and actually I wasn't the same patient that I had been when I was younger. As a result of my expert by experience roles, I knew how to communicate my own experiences. I knew how to ask for the things that I knew I was entitled to as a patient. And so I was a very difficult patient and much more critical of services. But actually it's made me a better researcher, and it will actually fuel me to do better research in the future. So just ending on that, second to final slide, where I have been, where I am now, where I'm going next. My mind is a time traveller, memories hold on to the past, my conscious mind makes sense of the present, and I dream of an unknown future. So I just wanted to end on the best achievement that I've ever done in my life is having received my PhD alongside my sister. So thank you.
Thank you very much for that. Thank you. If anybody has any questions, we have mics going around the room. No need to be shy.
Ask a question if you want, Susan.
Pardon?
You can ask a question if you want.
There we go. Brilliant. John.
Yeah, thanks for that. It's very reminiscent of the Eleanor Longdon experience, which you might be familiar with, the TED Talk. And started off as a patient and then ended up in one of the top jobs. Yeah, it's very much appreciated. Thanks.
Thanks.
Veenu, thank you very much indeed, and it's lovely to see you here today. Very, very welcome. I think we've seen changes, or very positive changes in research and research funding to involve people with lived experience. You know, and so there's the involved guidelines have been helpful, and research funders are much clearer about wanting to have lived experience in place. But I wonder, are there similar guidelines in place for education? HCPC ask for lived experience involvement in training programs for health professionals, but I don't see much in the way of guidance about how to do that well. And yeah. I just wondered what your reflections were.
So guidance around payments specifically? Payments,
but also involving people in a meaningful way, and making sure that their testimonies mean something, and that they also feel supported.
So there's a lack of guidance around payment, and I think these people always go back to the NIHR involved guidelines, don't they? And I'm not sure if there is actually any guidelines specific to HCPC, and I think they would almost always go with the NIHR default probably. In terms of how to do things meaningfully, there isn't much research out there, and I know that actually the Mental Health Research Innovation Centre at Liverpool are trying to develop tools to figure out how to do involvement in a meaningful way. So that I think they're going to be drawing on qualitative research, but also figuring out how to identify quantitative tools through that qualitative knowledge. So yeah, it's something that's not done, and there is space for it.
Oh, thank you. I think thank you. It's a fantastic presentation to help us think about how to, I guess, really support and optimise people who are already engaged as kind of peer researchers and experts by experience. I think, like, sorry, I don't know what your name was saying that, you know, inclusion and PPI are kind of, you know, skyrocketing in a lot of research framework. But I think there's still a need for that PPI to be more diverse and peer researchers to be more diverse. I just wondered what thoughts you had about how we can better facilitate lived experience from diverse communities to get involved in research as peer researchers.
Yes. I think someone was talking about how mental health patients are typically, people from minority backgrounds are typically likely to be diagnosed with psychosis or have horrible experiences of mental health services, for example. And I think actually what we need to do is build that trust back up with the communities. We need to reach out, not as, single research opportunities. What we need to do is build connections and trust with that community and then invite them to become a part of the expert by experience researcher role. I think even my mum, like I always say to her, she could be an expert carer, but there are different things that she's thinking about that influence her not to be. One of the things someone spoke about language, she wouldn't have the confidence to communicate in a room like this, her experiences of being a mum to me. So there are different things that we need to think about, but I think it's about encouraging trust and connection, and making sure that everyone in the room feels comfortable and that voice is heard.
You went for Claire. Go.
I first got involved in the lived experience movement about 40 years ago, and there was something wild and anarchic about our utter rejection of the system. And since then, I've become more ordered and more organised and more conventional. And I wonder whether we lose something when we lose our wild indignation.
If I could just add to that, it's a similar question I was going to ask. You talk about the history of psychiatry and that kind of really dark history, but if that's history, then at what point do we know that we've evolved from that and that we're doing better? What's the kind of goal in sight at the end of that?
Yeah, I mean, so there's two questions there. I think I have definitely become much more professionalized in the way I talk about my experience. And actually, it's easier to talk about it in a clinical diagnostic way, in a professionalized way, rather than talking from a meaningful kind of authentic experience, which leaves you a bit more vulnerable. In terms of coming a long way, how do we know that we've got better? I think essentially in lived experience roles and research rooms, we almost do recycle the same dynamics that occur in clinical settings. So when you're working with service users and the relationship with professionals, almost always that those same dynamics are going to be there. So I don't know if we've come a long way, but maybe we're hiding it better.
So there's no a lot of love. Okay. Inspiring and wonderful, and a privilege to hear you bring it to life.
Very cool.
That gets back with mine. So have one more question. Chris, you've had your hand out for a while. I'm so sorry.
Yeah, thanks. I'm going to kind of come at a different direction on the lived experience research role. I'm wondering whether or not there are limits there that we put on people in academia who have their own lived experiences. Is there a glass ceiling for academics that use the lived experience role?
So are there limits because we have to be in a particular institution and play by their rules?
Because we're using that lived experience brackets as opposed to being a researcher.
Yeah, I guess maybe we might be pigeonholed into having to do certain research projects, and there are limits to that. Yeah, I guess so. Yeah, there are limits. Sorry, I can't answer.